Guys hear me okay?
What was that?
Just making sure you could hear me. Just making
Yeah.
sure audio was working. So Freddie, Christine, Freddie. Um, Freddie is the vice chair of CHIPAC. We will be voting today on whether he becomes the chair. Christine's going to be our slide advancer. She's in the maternal child health unit, and she was with us at the last meeting presenting on foster care, the quality improvement project that we did.
Cool. Thank you, Christine.
Hi, can you guys see my screen?
Yep.
Okay, and it's not in presentation mode. Let's see.
Yep.
See it in
Perfect.
presentation mode now?
Yep. Everything looks good.
Yeah, thanks for offering to handle that discussion on
Yeah.
nominations because I didn't want to be
Yeah.
like
I think that makes sense. Yeah, I
I'm
can
running a
definitely do that.
coup, so I am taking over. Yeah, so
And I'll just segue to you for the vice chair piece for the Emily piece. That's okay.
okay.
Um, I realized that in the agenda that I sent you, I forgot to write vote next to the two candidates for membership, but that'll either, I don't know whether we would do that as, individual votes, but anyway, just I think there's a total of 5 things that we're voting on today.
I see. So it's the meeting approval, chair, vice chair, and then the two candidates.
And then the two candidates. Yep. Yeah.
Okay.
And
I printed this out because I'm old school.
yeah, I do too. And it's good to I think the best way to do it is to like I'll type it into the chat and then people can when we have these entirely online meetings, um I can't track voice votes at all and I'm supposed to be tracking votes. So it would be good if people maybe you can direct people to after I've written the instructions in the chat to say yay or to write yay or nay in the chat, um, if possible,
Yeah,
in
happy
lieu
to
of a
do that.
voice vote or in addition to a voice vote.
I'll just say instead of a voice vote, uh,
Okay.
clear instructions. And I think that seems easier,
Yeah.
right?
Like, well, I mean, you could say if people have difficulty, if you can't figure out, I mean, there
For
are
calling
those
in.
folks. You can't figure out if you can figure out how to unmute yourself, but you can't figure out how to write in the chat.
Yeah.
Then do whatever works for you. We'll make it work. But
Okay. Cool.
and
Cool.
Irma is not going to be at this meeting. And there's no sub. Apparently, DSS has like a meeting that everybody has to be at. So,
Okay. But we still have a
yeah.
quorum, I'm assuming.
Well,
If
I
anyone.
haven't heard. I did not hear one way or the other from most people, which usually means that they're going to be there. That people usually let me know when they're not. But I didn't do a head count.
Yeah, all good. I assume with the virtual nature of this, it would be easier for folks to join anyway. So
Right, right.
hopefully,
Should be.
hopefully we
Yeah,
won't have any issues.
yeah.
Are you all getting super excited for the workload coming up for
Yeah,
session?
we're preparing as best we can. We're a little bit short-staffed in the policy division. We're down one analyst from what we usually are, and we sort of coordinate the legislative analyses. So, and it'll probably it seems like it'll probably be a busy session. So, we're preparing as best we can. We'll see how it goes.
I have a couple of things I need to talk to you all about. I don't know who I
Yeah.
should reach out to. Um, one is like how we're using our HSI HSI
Yeah,
funding.
yeah.
Because I've seen other states they're using some of that for extending like famous prenatal postpartum coverage for up to 12 months instead of
Yeah.
like the 60 days. And
I could
then
talk all day about that. Like, feel
okay,
free to, yeah, let's set up a time and we can talk about HSIs.
okay, and then the other one was for the Cover All Kids program, we're
Yeah.
pretty interested. I think after talking to like a lot of enrollment folks,
Yeah.
of doing like an emergency Medicaid carve out, so we can continue to draw down those federal funds. And it seems like people could sign up for like both of those things on the same application, at least in that's like it seems like other states have done that. So I want to double check with you all about that because cost is always a thing. So are you the person to talk to me about that too, or?
Some of it potentially, yeah. We could start talking and I could maybe point you in other directions if needed. Yeah. Hi,
Okay.
Michael. Hi, Adrian.
Hello, hello.
Sounds good. Thank you. Thank you.
Yeah, I mean, just kind of some of it is just memory from the work group. I can kind of tell you what I remember, which isn't everything.
Yeah, no, I hear you. Thank you. All right, it's one.
I'm still checking for the quorum, but it looks like we're getting people quickly logging on, Freddie.
All right, you want to hang out a couple minutes or
Maybe one more minute.
sound good? All right. I think we're at a solid spot here. Hope, do you want to kick us off or should I?
I'm kind of waiting, still waiting for, I think we still have people rapidly joining. Do you mind if we just hang one more second?
I'm just obviously so eager to get started and hear about all the interesting things that people are going to share today. But yeah, well, I'm totally happy to wait until we have some more folks.
Okay.
This is partially a microphone test. Amy, I just love your festive background.
Thank you.
All right, I think we have critical mass. Freddie, I will just do some of the housekeeping at the top of the agenda here. First, want to say that there is remote captioning for those joining online. If you need it, I'm going to paste that link in the chat in just a minute, so you can paste that in your browser if you need the closed captioning. Want to announce that this meeting is being recorded and it's going to be posted on the DMAS website afterwards. Freddie, I'm going to hand it over to you to walk through the roll call because I think we have a quorum at this point.
All right, great. So I think we're going to go through the slides, right, for the. And you already have all this information, thanks to Hope. So I know Irma and the folks at VDSS are not on the call unless someone managed to come. I think they had a meeting today, so they couldn't send anyone today. But if I'm wrong, please share or raise your hands if you're here for Irma. All right. Do we have Dr. Susan Brown from the American Academy of Pediatrics, Virginia chapter?
Yes. Hi, I'm here. Happy holidays, everyone.
Great. Kelly Cannon. Yep. So we have Martha Crosby from Virginia Community Healthcare Association.
Here.
Heidi Diggs from the Virginia Association of Health Plans. Okay. Shelby Gonzalez from the Center on Budget and Policy Priorities. Okay. Emily Moore from Voices for Virginia's Children.
Hi, I'm here.
Awesome. Do we have Amy Edwards joining us in place of Alexandra Javna from the Virginia Department of Education?
Here.
Thank you. Do we have Estella Obi Tabit from Joint Commission on Healthcare?
Hello, everyone. Happy holidays.
Hello. Jennifer McDonald from Virginia Department of Health.
I'm here.
And I am here from the Commonwealth Institute for Fiscal Analysis. Michael Muse from Virginia League of Social Services Executives.
Good afternoon, I'm here.
Awesome. Emily Roller from Virginia Healthcare Foundation.
I'm here. Hi, everybody.
Hello. Hannah Schweitzer from the Department of Behavioral Health and Developmental Services, DBHDS.
Hi, I'm here.
Great, thank you. Dr. Nathan Webb from the Medical Society of Virginia. Okay, I think that is it in terms of our roll call. Is there anyone from the DMAS exec leadership team on?
Hi, everybody. This is Jeff Lenardi. I know Cheryl was hoping to join. I'm not sure she's going to. Just wanted to say hello. Good afternoon. We appreciate everyone joining. This is a very strange meeting for me. It's the first time I'm joining on this side of the meeting. I was a CHIPAC member for a couple of years prior to my current role. We've got a couple former CHIPAC members on the DMAS staff right now, so it's a good career move. And we just appreciate everyone's time and continued work looking out for this really important part of our Medicaid population and making sure that we are doing everything we can to deliver the services that they need. So thank you. And I'll be on the call for a little while. listening and taking notes. And then I will have to drop off in about 45 minutes. But thank you.
Thank you, Jeff. And I see Shelby has joined us, so just want to make a note of that for the records. All right. Well, we're gonna get into some business now. We have, I think, 5 things we're voting on as a group. For this time around, for voting folks, if you want to vote in the chat rather than the voice vote, that would be our preference. So Hope is gonna paste a prompt into the chat, and if folks can write yes or no or yay or nay into the chat, that would be the preferred option for how we're gonna vote for these things. If you can't get to a chat right now, if you're joining by phone or for whatever reason, you can't do the chat, you could unmute yourself and say yay or nay. But it's just a little easier for us to kind of count the votes exactly like who's saying what in the chat. So yeah, and just let me know if there's any issue with that, any of that. So I think I can do the first vote here, which is reviewing and approving the minutes from our last meeting on September 7th. So if you want to take a look at that, I do need motions. And I see a motion to approve from Kelly. We need a second.
It's like we have one from Jen McDonald. Things are a
Perfect.
little out of order, but it'll work.
All right. All right. And it looks like we are good to go on that motion to approve the September meeting minutes. With that, I'll pass it over to Hope.
Yeah, thanks, Freddie. So I just want to kick off our update about the committee leadership. I think most of you know that Sarah Cariano is DMAS's new Director of Eligibility Policy and Outreach. So she has stepped down from her position as CHIPAC Chair. And Freddie Mejia is our current Vice Chair. At the most recent Executive Subcommittee meeting, the Executive Subcommittee nominated Freddie to move into the chair position. So we are entertaining motions to confirm Freddie as the CHIPAC chair. Okay, I see Jen McDonald has a motion and Shelby is seconding. So I'm going to just, yes, paste into the chat that we're going to vote on Freddie as chair. We have a majority.
Great, thank you,
All right,
everyone.
congratulations, Freddie. I'll
Yeah,
get you
thank
for
you.
the next piece of the leadership update.
Yeah, definitely appreciate those votes, and I'm obviously looking forward to continuing working with you all. Sarah has left some very nice and big shoes, but I'm looking forward to continuing these conversations and advancing policies that are going to help our children here in Virginia. So that's my big spiel right there. Appreciate the votes for yes, and with that, I'll move over to the nomination of Emily Roller as vice chair. Emily Roller has been a part of CHIPAC for a while now, and really serves just a really amazing role so we at the executive level nominated her for vice chair, and so I would motion to approve her as vice chair for CHIPAC. It seems we have a second by Shelby.
Yeah, we'll take that from Shelby. Is that a second? And then now we're voting. All right, congratulations, Emily. You are the new CHIPAC vice chair.
Thanks. Look forward to continuing to work with you all in this new capacity.
All right, great. So those were the changes in committee leadership. I'm gonna respectfully ask the mass to keep their hands off of Emily or myself. Uh,
No promises.
Definitely love working with all the folks in CHIPAC. So you know, uh, so yeah. So next up, we have a couple candidates to join the committee. As you know, we've been seeing some changes within the committee with folks moving different places. So first up is Pinda Sutton L, who I believe is a CEO over at the Birth and Color. Um, do you want to give some more context on that, or?
I will just direct folks to the meeting packet that we circulated prior to the meeting. So we have these two new member nominees that the executive subcommittee nominated at the last meeting, last subcommittee meeting, Kenda Sutton L and Sarah Bedard Holland. And we're going to start, I think we'll do these votes one by one, but we would need a motion to entertain a vote to confirm Kenda Sutton L as a new member.
See, we have a motion to confirm. Can we get a second?
Okay, thanks, Heidi. Okay, I think that Kenda Sutton L is confirmed as a new member, and we can move on to the next vote. Freddie, do you want to start that?
Yeah, and just quickly with Kenda, you know, we certainly are excited to welcome her. She just such a strong presence in the maternal health field. So we're looking forward to welcome her to CHIPAC. The next candidate is Sarah Bedard Holland, who is a powerhouse in the Virginia Health Catalyst, is the organization she leads. So more information, obviously, in the candidate questionnaire. But if we could, we're taking any motions for confirmation to CHIPAC for Sarah Bedard Holland. So entertaining a motion. Thank you, Emily. Do we have a second? Thank you, Heidi.
Okay, we have a majority, so we can confirm Sarah.
Awesome. Thank you so much. So I think those 5 actions were the votes that we had for this meeting. So we'll be yeah, it's really exciting news. And I think we can now start moving on to the first update or presentation of the day, which would be unwinding update from Jessica from DMAS.
All right, sounds good. Good afternoon, everybody. Welcome to the final CHIPAC meeting for the year. Always good to see, our faces moving into those leadership roles. So congratulations to Freddie and Emily. And always good to see some new members coming on as well, especially because my updates are usually the same, just new numbers. So always good to show the information to new people as well as give updates to those that have seen our progress through the year. All right, we can go ahead and head into the next slide. So these are going to be our general unwinding data updates. So this is our dashboard. Now, our dashboard actually was just refreshed. It's refreshed on Thursdays, and it happened at about 11 a.m. this morning. So I do have updated numbers for you. They're not on the slide here. But we did increase about 30,000. So our total numbers that are determined, and that's of our refresh of yesterday, at 1,384,424. And no worries to whoever's taking the minutes. I will make sure Hope has a copy of the updated data because I know I'm going to say a lot of numbers. So our closed, because this is the new month refresh, of course, this is the week where our number of closures is the highest because we roll over anyone that was closed the end of the previous month. So that number is 231,988. And then our number renewed is 1,152,436. So basically, we are just under its 63.9% completed, which is pretty amazing. December is month 10. We prepared for so long and it is flying going through these unwinding months. So we basically have 83% of those that were redetermined remain enrolled. That does mean 17% have closed. And that's right along with our projections. Of course, we projected a 14% closure rate and a 4% churn. So of course, because we rolled over some new closures, we know some of those will come back to us. We can go ahead and go to the next slide. And then this slide just goes over the eligibility closures by our eligibility groupings. So again, this is just all the different 8 categories kind of grouped into 6 main groups of coverage. As you can see here, the thing that we focus on the most here is, of course, children's coverage. That was definitely a big factor in some systems changes that went in recently to protect children's coverage wherever possible and to kind of look at things on that individual level. So what we've seen, and especially because of that, the gap between the children's closures and the non-ABD adults is growing. And that's what we expect to see. So we are seeing those 2 groups are going to be our highest. They're our highest number of enrollees, but the gap is growing. So that means that we are keeping those children enrolled that are supposed to remain enrolled. All right, we can go to the next slide. And this just breaks down our top closure reasons so you can kind of see how the trends are going. I'm trying to think if I'm looking through here. The trends have stayed mostly the same when you get to kind of the deceased members and the recipients that are requesting cancellation. Sometimes those flip-flop because they're very close to one another. Otherwise, the ranking, I would say, of the closure reasons is still about the same. And then we put the procedural closures at the end because, of course, you would add up all non-procedural reasons and compare those to procedural to see we are very well on track that were outweighed by our non-procedural closures, the ones that were closed for determining ineligibility rather than those that didn't turn in information. I think a lot of people on this call are to thank for that as well. Our health plans, they do a lot of outreach, but of course you all see people in the community and you're helping them on a daily basis. So it's really good to see, that we're able to, if someone is closed, it is a determination of eligibility. Not knowing, what their eligibility is a little more troublesome because you don't know what if they're eligible or not. We can go to the next slide, which actually might be my last slide, which is basically just the comparison. So you can actually see when we look at those coverage groups and we compare procedural versus non-procedural closures. So as usual, limited coverage is usually where that's, you know, the most equal between procedural and non-procedural, but in every one of our groups, the non-procedural closures outweigh procedural. I'm trying to think, next slide, I can't remember if I have another one or not, that might be it. Oh, ex parte. So you guys can see our ex parte rates as we are going through. We did see that bump in September when we switched to a more individual review. We are now getting into the season, usually October through January-ish is where we see the greatest bulk of our expansion renewals, because of course expansion started in January. So all of those months within that are usually where the bulk of our enrollment lies. Because that was projected to be our highest loss, that would be why also our ex parte rates are a little lower than what you saw in September, but we're still doing better than we were prior to the PHE. So some good systems changes going in there. You can kind of see the number of packets sent. You can see the case level versus member level, approval rates, and the numbers. And I know I had like almost a half an hour to go over, but I think that was actually my last slide. Just some generic kind of policy, or not policy, number updates there, data updates. I'm sure everybody doesn't mind us getting ahead in the agenda, but of course I'll pause here for any questions anybody has.
Yeah, thank you for that information, Jessica. Do folks have any questions?
And of course, like always, I should be able to stick around for the entirety of the call. So if anything comes up, because I just went really quickly through the slides, you guys know you can put it in the chat or just call me out and I'll come back on and answer.
Thanks, Jessica. And you know, I just did want to ask a quick question on there's some new information now, I think, on the overall procedural closure tab, right? Like around reinstatement within the first 3 months. So the churn that you mentioned at the start, right? So could you tell us a little bit more about that,
Sure.
or yeah?
Yeah, and completely up to you guys. If you want to stop sharing, I can share my screen and show that tab. So if anybody hasn't gone to the dashboard and they'd like to know what that looks like, if it's a little difficult to unshare and share, I can just give a verbal update. So that's just up to you guys what you want me to do for that. Okay, I'll go ahead and start speaking on it. So we did add a procedural churn dashboard. So the way that we look at this for procedural closures is if someone is closed, they get a 3-month reconsideration period if they are closed for failure to provide. That means they basically have the 3 calendar months after their effective date of closure to return their information, so we can review them without the need for a new application. So what have some states have started to do is actually look at those numbers to see what it looks like, who's coming back to us. So that is on the dashboard. And it looks like Freddie did link the dashboard, so thank you for doing that. And it is the last tab on the dashboard. What this does is it lets you know for each month of closures who came back within the first, second, third month, and who was not reinstated. I don't have the exact percentages right now. In basically the way that you look at this, each column that's on the main chart is the effective month of closure. And then the color bands represent out of each of those cohorts if they were reinstated and if so, when. And so you can kind of see, and this is the same thing that's along the lines of other states. The bulk of the reinstatements do occur in the first month. That is pretty much aligns with how we kind of were before the PHE, but it is a little bit more centralized there. And we think the reason is because of all of the outreach that's being done, you know, to ensure that if someone's closed for a procedural reason, again, our health plans are doing a lot of outreach. We do have some fee-for-service outreach as well. You know, to say, hey, you don't need to reapply. You know, just make sure you turn in your renewal or your information. That's, again, it kind of steps down month by month. So the most come in the first, and then the second, and then the third. Still a pretty good number, though. I'm kind of doing my rough math here in my head. It's a little over, it's about 150,000, you know, that we look at here. And I would say about almost a quarter of them are coming in within the first month. Please don't quote me on that because I'm doing really fuzzy math in my head. But it's really good to see that, you know, almost 9,000 people still came back to us in their third month. And that's pretty good. You know, a lot of times you think, well, if we don't hear from them right after they get that closure notice, you know, we might not hear from them at all. So really good to see that. It breaks down the information by the demographics. age, race, ethnicity, gender, as well as region. You can also look at it through the eligibility categories that we kind of gone through in the presentation. But a really good ad because again, it just kind of tells us when are people coming back to us, and kind of the overall percentage that are coming back. So it's really good to see this. It's actually a little bit higher in terms of the percentages than what we saw pre-PHE. So that's what we wanted to see. You always want to see those numbers go up because if they're eligible, we want to see them come back to us.
Cool. Thank you so much for that extra context, Jessica. There's so much information on this, which is so awesome for folks like me who are, interested. And so I really appreciate DMAS providing this information on this public dashboard with so much information around the data and demographics. And I will just note that you can look at it through eligibility category and just look at like what's happening with kids since this is the CHIPAC meeting. So yeah, thank you for kind of presenting that on your feet. I apologize for not asking for anything ahead of time, but again, just thank you. And I guess, any last thoughts or questions before we move on to our next agenda item?
Does look like Shelby has her hand raised, so go for it.
Hi. Thank you so much for the information. I'm curious if there's anything you can share about what the experience has been with the interaction of individuals coming off of the unwinding and finding that they're ineligible, and or even those, I guess it would be more tricky with the people for procedural closures, but the people who are ineligible, how has the interaction been with the new marketplace? Do you know anything? Are you all tracking data? Can you tell us anything about what kind of combined outreach is happening or anything along those lines?
Sure. I will get started. I'm not going to put Jeff on the spot, but if he wants to add anything, he can. He's been one of our big DMAS partners for the exchange. In terms of the data, of course, because everything is reported pretty much on a monthly level per the contract that we have. Oh, so we don't have necessarily the numbers just yet. So hopefully we'll have more information on that just in terms of how things are coming and going at our next meeting. We did communicate with the exchange even before it came up. I talked with a lot of the people over at the SEC for, oh my gosh, probably the years leading up to unwinding. So just making sure they kind of understand our plan. If they're going to put the communications out there, they're, the same thing we asked of the stakeholders, use our language, of course, put your logos on it. So there's been a lot of coordination to make sure that, people are finding that transition to coverage without any sort of gaps or that long time frame between losing Medicaid and gaining coverage somewhere else. So so far we've heard positive feedback about the exchange. They launched last month. We've not received necessarily negative feedback or anything on it. It's actually been somewhat quiet, which is good news. We definitely want to make sure that things are successfully launching. We do have another about 45 days left in the open enrollment period. Jeff, I'm not sure if there's anything else you want to add to that, but yeah, I would just say that we're still constantly communicating with them, even though it's implemented. That doesn't mean that, we've kind of gone off onto our own silos, but I think that's something that maybe we can also think about for the next meeting as well, even bringing them in and seeing if we would do a joint presentation or they can give us an update on, how things are going over there.
All right, thanks, Jessica. Any other questions or thoughts? Looks like we might have opportunity in the future, maybe discuss the exchange and the interaction with CHIP and how that's going. So in the future.
Yeah. And I did see Michael Muse's comment in there. I know that DSS would normally give an update, but yes, they are doing a phenomenal job of completing renewals. I mean, you can kind of even see when I said the number updates between, the slide that I showed you and, the numbers that were updated today. There are sometimes tens of thousands of renewals completed just in 1 week, but they are doing an excellent job of trying to get through that work, especially because ex parte is usually not successful for, than non-Magi cases that are the more complicated. They usually have a lot more paperwork and a little more back and forth. So yes, I agree, Michael. So definitely want to shout out DSS and all the work that the state and the local agencies have been doing to get through this basically unprecedented event. I still say it's unprecedented. There's nothing that we've seen that's been like this. Emily?
And just a question / sort of also a comment. I think one other thing that we do see is the anticipated move of some kids from Medicaid to CHIP, which I think is a positive sign. It's not they're falling off of Medicaid. They're rolling into CHIP, and I just pulled the enrollment report that's not quite up to date for December yet, the monthly report, but I suspect we'll continue to see growth. And I just wanted to see, is that something that you all anticipated would go as it has, or were you thinking there would be more children moving into CHIP at this point, or is that kind of tracking as expected?
Yeah, so unfortunately, like we can, use our normal projections of movement and things like that. We think that everything will be a little bit more amplified because we probably gained a lot of people in Medicaid because the income was no longer available to them when the PHEs started. So I would say we haven't seen necessarily anything that's been a flag to us. So the movements are, they're occurring. Also because of, the changes we made, we're also seeing, those children who are turning 19 that are also now getting to go into expansion or Life See if they have their own children. So something that we didn't see pre-PHE because of the way that we were reevaluating people. So that's also been a really good thing to see, is that the continued coverage, not only for those moving within coverage groups because of financial reasons, but non-financial reasons. So just as much as we like to see, the correct movement between Medicaid and CHIP, again, we're seeing some of those 19-year-olds getting into expansion coverage. So good for them to keep the coverage, good for us because expansion's a higher match rate. So we always like having that as well.
All right, great. Thank you, everyone. I think with that, we can maybe move on to our next presentation. And thank you once again, Jessica, for joining us and answering those questions. The questions were a little longer than the presentation.
That's all right.
Yeah.
That's what I like. I would much rather have more communication and back and forth with you guys than just me talking to you. So always appreciate questions.
And we appreciate you. Thank you. Next up, we have I believe it's Sarah Cariano.
How to say my name already, Freddie?
Is that pronounced? Is that how you pronounce it?
Yeah, you got it. You got it. Good
Okay.
nice work.
Yeah. So you have an update on DMAS policy and eligibility updates. So I'll let you take it away.
Yeah. Hi, everyone. Nice to see you again. Same as Jeff. Weird to be here on this side, but very happy to be back around some of my advocate friends. We're just going to do a brief overview of the 12-month continuous eligibility provision that is going into effect January 1. So as a reminder, this is mandated by federal law through the Consolidated Appropriations Act. And we've been busy trying to get all our systems and guidance and trainings up to date to reflect this new policy guidance. But we definitely want to make sure that we have help getting the word out to families and community members. And so please do let us know. We're in the process of making some fact sheets and member-facing materials as well. So if you or any of the organizations you work with would be interested in those down the road, let us know and we'll get them to you. The kind of high-level overview is basically that kids can't lose coverage between their eligibility period at this point. So continuous coverage means that it is a protected period of coverage during which things that would normally result in someone losing coverage prior to their renewal, such as an increase in income, will no longer result in that loss of coverage until the renewal date. And then if at the renewal date, so that at the end of the 12-month period of coverage, that individual is now over income or no longer meets one of the other eligibility criteria, then they would potentially be terminated, but not during that 12-month period. With everything the CMS, there are exceptions if the child turns 19. So when someone kind of ages out of the eligibility category, when they turn 19, there would need to be a new review. If someone leaves the state, because Virginia Medicaid doesn't want to cover someone who doesn't live in Virginia, they should get covered in their state. The member or the representative, the parent requests that the coverage is terminated. So obviously we're going to respect the wishes. If folks don't want the coverage anymore, they can always call and ask for it to be ended. And if it was found that the initial eligibility determination was an error or due to fraud, it can be ended. And if a child passes away, the coverage would be ended as well. There are a few other kind of nuances that go into this, and I will talk about some of those, but definitely I'll be around for questions as well. So coverage can't be reduced either. So because of that provision, a child who is in Medicaid cannot be moved into FAMUS because our Medicaid benefit package is a bit more robust than the FAMUS benefit package. We have early periodic screening, treatment, and diagnosis. We have the non-emergency medical transportation. And so a child cannot be, quote unquote, reduced and moved into the FAMUS category. If a child is in FAMUS and does experience a drop in income, they can be moved into Medicaid during the 12-month period, right? So you can get better coverage. We just can't take access to specific services away by reducing your coverage. And then other health coverages. And if a child, so this is a lot of times when we're talking about this, we talk about the financial eligibility changing during the course of the year if someone's income goes up. So we do just want to remind folks that if the non-financial eligibility criteria is no longer met during the course of the 12 months, that also will not impact the child's coverage. So if a child in FAMUS obtains coverage through an employer, other health insurance that would normally make them ineligible for FAMUS coverage, they're able to keep that until the end of the 12 months. And then again, that would come up during the renewal process. If a child has an eligible immigration status and it is lost, so say someone has a pending asylum case and they lose the asylum case, and so they no longer have eligible status, they will also be covered until the end of the 12-month period. So any of those other factors that are changing with the, except for the ones on the list, like moving out of state, the child will remain covered. This also impacts our medically needy population who typically have 6 month spend downs. If a child meets a spend down within that 6 month period, they will not get a new one at the end of the 6 month period. They basically will get the full 12 months of coverage there as well. We all know that most of our newborns are already what we call deemed eligible, so automatically enrolled if they are born to a parent who is enrolled in Medicaid or FAMUS. The one exception to that right now is the individual is in FAMUS prenatal because the policy behind that group is slightly different. For those children right now, they are assessed when they are born to see if they are eligible. And if they are enrolled in a 12-month period of coverage. But if a child is found not to be eligible or the agency needs additional information and it is not returned, that child can be terminated. Once this policy goes into place, those children this gets a little confusing. So they would remain in coverage until the end of the 12 months that began when the pregnant individual got enrolled in coverage. So if the pregnant individual was enrolled in month 6 of their pregnancy, had the child, and their an unmarried partner lived in the house and they requested their income and they didn't respond, the agency that child would be eligible for an additional 9 months of coverage because the 3 months when they were the pregnant individual was enrolled, and then the 9 months to cap out the 12 total of enrollment until their next renewal. So that's possibly one of the most complicated pieces of this rule. Other than that, it's really straightforward. Kids in coverage get to stay in coverage for 12 months unless one of these exceptions are met. The one other exception is it also doesn't cover individuals enrolled through hospital presumptive eligibility. So it does need to be a full and complete eligibility determination for the 12 months to be granted.
Great. Well, I really appreciate you giving some concrete examples of how this would play out for folks, for children, and obviously really exciting for Virginia to hopefully reduce some of that churn that children might experience with changes in their family throughout that 12 month rather.
CMS is going to approve 12 year, but Oregon, Washington have up to 5 year in one of those states, but 12 might be a bit of a stretch.
No, we don't know the answer yet, right? So maybe we should ask. But do folks have any questions around this 12-month continuous eligibility policy that's getting rolled out in January? Okay, looks like none. Once again, you are always very thorough with everything policy related. So I think we're good to go. So
Awesome.
we're
Well,
excited to see it
that's going to
implemented.
be around, and I think most of y'all know how to reach me. But if you don't, Freddie and Hope can help you get in touch if there are questions down the road. And just thank y'all. Nice to see you.
Great. Thank you, Sarah. All right. Next up, we have an update on Cardinal Care. So it looks like we'll be joining, Lynn Vest and Jeanette Abelson.
Hi there. Can you all hear me?
We can hear you.
Great. I just tried to press on my camera for just a minute. It didn't go, but if it's okay, I'm going to go ahead and get started. I actually need all the minutes I can. This is my first time talking to this group about Cardinal Care, as it is very new. Jeanette couldn't be with us today, so you got me all the minutes. I am a member and provider relations specialist with our managed care program. So I'm kind of the person that hears from families, hears from providers if they're having issues through the managed care programs, and I connect them with their health plans and advocates. So I'm kind of very, very front-facing, people-facing to this group. So I really thank you all for having me here today. And I'm also going to talk about, I'm going to talk about Cardinal Care, and then I'm going to talk about the model of care that goes with Cardinal Care. So you can go on to the next slide. Thank you. So Cardinal Care is a new brand, a single brand. It used to be called Medicaid, right? Virginia Medicaid's program. But now we have transitioned to Cardinal Care, and we actually, you can go on to the next slide. Thank you. Cardinal Care, we basically started with a name change back in January of 2021 because as part of the 2021 Appropriations Act, DMAS was directed to merge the two Medicaid managed care programs, Medallion 4 and CCC Plus, in a manner that links seamlessly with the fee-for-service program. And again, the strategy was we did this in phases. First, we did the name change to Cardinal Care, and our members got new insurance cards with the Cardinal, and that included members that were in fee-for-service, famous, both the Medallion 4 and CCC Plus. So that started, and this was happening all while we were waiting to hear from CMS to get approval for us to merge these two managed care programs. So it is happening. It's happened, but it did happen in phases. We did receive approval to consolidate both the Medallion 4 and the CCC Plus program under Cardinal Care Managed Care, which I'm going to now refer to as CCMC, if that's okay with you. Otherwise, I'm going to get tongue-tied. But that was effective October 1st. So this really did build provided the strong foundation for the governor's priority initiatives, which included the Right Help Right Now and the managed care procurement. You can go on to the next slide. Some important facts about Cardinal Care is it did include and does include all existing managed care populations and services, and I'm going to go into that in a few minutes. What you need to know is all of our members have seamlessly enrolled and transitioned into Cardinal Care, received their new insurance card, so that has already happened. They were able to continue their enrollment with their same managed care organization and keep their same providers and doctors. So I know that was kind of a concern for our families, but that did happen. And it's important to know that full implementation of Cardinal Care Managed Care is requiring up to 60 days from that October 1st start date. For instance, you're still going to hear the words sometimes CCC Plus and Medallion 4. I mean, eventually over time, those names are going to be phased out and it will just be Cardinal Care. But another important thing to note is the CCC Plus waiver, or I'll just continue to call it that right now, is going to stay the same. So CCC Plus waiver, members that are receiving home and community-based waiver services at home in the community, that's still going to be called CCC Plus waiver, not so separate from Cardinal Care. So just wanted you to know that. And the most important, to me, one of the biggest plus for this is our members in Cardinal Care. It improves the continuity of care for these members because they no longer need to transition between two managed care programs when their care needs or their levels of care change. And sometimes they were dropping into fee-for-service, depending on what was happening within their care. And that can be very disruptive and has been. So this is a big improvement, and I'll go into that in a minute. Next slide. All right, so all right, I'm going to try to get through this as quickly as possible, but this is what has really changed. These are the biggest changes. So coverage under Medallion 4 and CCC Plus varied slightly for the services listed below, but the Cardinal Care Managed Care Program has aligned, I think, what is best from Commonwealth Coordinated Care Plus and Medallion 4, and put them into a process that makes sense and is working really well for continuity of care for our members. So the 3 bullets that I'm going to go over started November 1st of 2023. So members before who were hospitalized at enrollment under Medallion 4 rules, their managed care enrollment was delayed until a member was discharged from the hospital. And, you know, when I think about that and when I saw that in action, what that means is when a member is being discharged from a hospital or another level of care, there was not care management or care coordination on the health plan side. They've dropped into fee-for-service and didn't have care coordination. So now the Cardinal Care Managed Care aligns with the CCC Plus rules, again, taken, you know, a best practice. So members who are in the hospital at the time of an initial MCO enrollment will enroll in Cardinal Care Managed Care. And then when they are discharged, they're going to have that care coordination and that support of the health plan, not dropping into fee-for-service, not having managed care. So nothing changes and that continuity stays the same. On the billing side, hospitals continue to bill what's called the inpatient DRG as they do today. Nothing's changed. So basically, if a member did go in as fee-for-service, not having an MCO, then the provider is going to bill whoever, if it's fee-for-service, would bill who at fee-for-service at the time that member was enrolled at admission for the entirety of that hospitalization. Conversely, if a member started as an MCO in the hospital with an MCO, the hospital, if they bill DRG, would bill the MCO for that entire stay. So that's for people who do billing and that matters for them. The second bullet is about newborn enrollment. Under CCC Plus, newborns of CCC Plus mothers were first enrolled into fee-for-service. So that's what was happening with CCC Plus prior to enrolling in managed care. So first fee-for-service, then managed care. But now Cardinal Care Managed Care aligns with Medallion 4 rules so that newborns of Cardinal Care mothers will have the coverage through the birth mother's MCO for at least birth month plus 2 additional months time frame. That's been in place with Medallion 4 for years. So again, taking that best practice of what works well and what is best for those mothers and babies. The third bullet, long-term services and supports and hospice services. So under Medallion, again, when they are 2 separate contracts, members who needed long-term services or hospice, they were disenrolled from their managed care and put into fee-for-service for a time before re-enrolling into managed care. That could be a month or 2, depending. But now Cardinal Care aligns with CCC Plus so that those managed care populations who elect hospice or enroll in long-term care programs, they're not disenrolled as they were in Medallion 4.0. So I know that was a lot, but basically just think about it as, it's one program now, and there's not going to be that transition between, Medallion 4, fee-for-service, just because of changing of levels of care. And again, that preserves that continuity of care. Next slide, please. This slide just shows that the same populations that were in Medallion 4 and CCC Plus, same populations, but now just one, all 5 health plans under one contract serving all of our members. So I'm not going to read the slide, but there are nearly 2 million managed care members, and this is our population. And the same populations that were excluded from managed care are still excluded today. And one example would be HIP, the Health Insurance Premium Program. Those members never went into managed care. They were always fee for service, and that is the same case as it is today. So the same exclusions, same populations. Next slide. The managed care services. So with CCC Plus and Medallion 4, same services are covered under Cardinal Care Managed Care, no different. They're just now, again, all covered under Cardinal Care. The DD waiver members still are carved out of Cardinal Care, and those DD waiver services are paid for through fee-for-service through the Department of Behavioral Health and Developmental Services. But that same member who needs medical care would still have an MCO, a managed care organization, for those acute needs, hospitalizations, and things like that. It's just those DD waiver services are carved out of managed care. School services are carved out, paid for through fee-for-services, as well as LTSS screenings. I think someone was speaking, I'm not sure. Thanks. Some Cardinal Care managed care improvements. Again, a single contract instead of 2 different contracts with our health plans. Preserves the continuity of care managed care enrollment. I think you all saw, we demonstrated that. I'm going to talk about the responsive model of care quite a bit, as quickly as I can. And aligned open enrollment. Our members in CCC Plus had an annual open enrollment, and our Medallion 4 members had a regional open enrollment. Well, now we all are on a regional open enrollment. So that's a nice thing to have everybody on the same page, having one number we have a single website for our Cardinal Care members when it's time for enrollment for them, if they want to change health plans when their regional time comes. So again, not 2 separate time frames, which I think could be confusing. Definite enhanced oversight and accountability. Next slide. And this is the last slide on just regular Cardinal Care. Our providers continue to contract with the same 5 MCOs, actually, since Virginia Premier and Optima are now one Optima. And they continue to use the same authorization and billing processes, no change, unless they're told by the health plan they continue to do the same thing. We always encourage everyone to be checking Medicaid eligibility. As we know, we've just heard a lot of things going on with unwinding, people kind of coming in and out of Medicaid, a lot of changes. So we always, want our providers to be checking Medicaid eligibility. Next slide. All right, I'm going to go into our Cardinal Care model of care, but before I do that and transition, you can go back, thanks. I just wanted to mention briefly some updates. You can go back. I'm not ready for that one yet, but just wanted to go over some updates on the maternal and child health programming happening at DMAS that haven't been mentioned, because I think this is of special interest to you, hopefully. As mentioned under CCC Plus, the newborns of CCC Plus mothers now have coverage their birth month plus 2 additional months. Baby Steps Virginia is an initiative aimed at improving maternal health outcomes for all pregnant and postpartum women and to work toward eliminating racial disparities and maternal mortality. DMAS has made strides in addressing birth outcomes, social determinants of health, barriers to care, and member provider engagement. The 12 months postpartum continuous coverage is another change. Medicaid and Famous Moms members now receive guaranteed health coverage for 12 months following pregnancy, and the expanded coverage enables new parents to receive critical postpartum care. It's an important step in improving health outcomes for birthing people and their babies, and this is a change from the previous policy that provided coverage for 60 days after the end of a pregnancy. DMAS is also working with our federal partners at the Centers for Medicare and Medicaid to finalize the evaluation plan for the postpartum coverage, including outcome measures that will help us track and report progress toward the demonstration's goals of improving maternal and infant health outcome and reducing disparities. And just the last update on that is the community doula program. And to date, 125 doulas have received state certification. Of the 125 state certified doulas, 90 are approved and enrolled as Medicaid doula providers. And there have been 107 doula-supported births to Medicaid members, and over 304 birthing families have received doula services through Virginia Medicaid. Feedback continues to be positive from families who have received care and support from a doula. DMAS continues to focus on increasing the network of doula providers, community and provider engagement, and data. And the availability of state-certified Medicaid-approved doula providers within the Commonwealth means greater access to care and support for pregnant people, and with the goal of improving maternal and infant health outcomes, reducing infant and maternal, mortality, and helping to address racial and health disparities. So I'm sure some of you either know about these updates, have heard them, but there were some new people, and I just thought it was really good to go over that. Hopefully that was helpful. And I'm ready to move to the next slide. Thanks so much. So as we talk about the model of care for the Cardinal Care Program, just want you to keep in mind that it's the framework or foundation for ensuring the delivery of high value care, the right place at the right time, while protecting the health, safety, and welfare of Cardinal Care members. So when we say, you can see the title of this slide is Responsive Model of Care, we focus on the member needs and where they are at any given time. And so this model of care provides access to care management services across populations. The model of care is a driver of improved health outcomes and looking at improved quality of care and clinical efficiencies. I'm going to say, when I look at this, to me, I'm looking at our members are constantly moving from one, not constantly, but many members, let's say, sometimes are in a very not a great situation. They're at home, they're fine, and then they're in the hospital, and sometimes they're in a skilled nursing facility coming out to home. And what we see is in this model of care, and I think it's an improved model of care, is that our members are going to be able to get the right type of care coordination at the right time, more intensity, less intensity, based on what they need, not based on what population they fall in. It's really what they need. Next slide, please. All right, so this one talks about the care management intensity. The model of care offers 3 levels. So it's based on, again, the member's needs and risk from high intensity to low intensity. And for those members with minimal needs, will receive care coordination, which is more episodic and issue resolution, where care management is more oversight and assistance. The previous model of care was based on populations, while the current model of care is based less on what population they fall under, and again, more on the member's current risk and needs. So in doing so, we look at a data-driven model to look at the appropriate and timely interventions to drive the right care at the right time. Next slide. Thank you. All right, so when I look at this, supporting the member care management components, our providers are really working, they're the one boots on the ground. Our providers are taking care of the members. So the MCO care managers partner with providers on behalf of the members. They're also partnering with the member and their family as a resource, from that MCO. And again, really supporting the providers who are taking care of our members. Facilitating successful transitions between level of care settings, like exactly what I said. Members are not always staying in the same place when their care needs are changing. So that care coordinator is going to be able to follow that member where they are, making sure they're getting that right care at the right time. Establishing wraparound community support and serving members who have social determinants of health needs. And I talk to so many members who, it's really hard if you don't know how you're going to eat or where you're going to live. It's very hard for them to focus on their health needs. And so our care coordinators are very experienced in helping them find housing, helping them get to food pantries, helping them get what they need at that right time. So that's what I kind of wanted the takeaway to be. Thank you. And this slide is an overview of the model of care design and just a few things. This is a lot of information I'm giving you, and I understand that, but I wanted you all to have that as a reference. But I'm just going to kind of pull 3 of the features of the model of care, which is allocating care management resources equitably across populations based on the member's need and risk level. I think you're hearing that a lot, with special attention to the Commonwealth's most vulnerable populations, such as vent-dependent populations. Supports, right care, right place, right time. Can't say that enough, real time. And maximizing the use of the limited management care resources. So just keeping in mind that this design allows flexibility, especially as someone, again, transitions between different levels of care and care settings. Next slide. All right. So here's a summary of what changed and what stayed the same. Again, a lot of information for you to look at later, but with my limited time, just wanted to go over an overview for you. People have asked, what is the difference between the old model of care and then this revised model of care? And this slide outlines what is the same between what's less stringent, what's different, and what services are the same. And the Medicaid managed care health screening is something that happens, that stays the same. When members come into the health plan, they get a screening to see where they fall, stratification into where they need to be, what risk level. Individual care plans, they stay the same, still maintaining person-centered care, but we've relaxed some face-to-face requirements. We've broadened staffing qualifications, and we've allowed more flexibilities where we can to adapt in the changing care needs. What's different is that we now have care management levels of intensity, as we talked about. So standardized terminology, definitions. We have leveraged our MCO's advanced analytics, and we have reinforced our care management efforts to qualify outcomes. There's a lot of information here, again, that you can look at later if you're interested, but the new model of care was built upon what we knew was working well with Medallion 4 and the Commonwealth Coordinated Care Plus program, and those are in the first column. And then there were things we knew had not worked exactly as intended with the CCC Plus design, for example, the interdisciplinary care team meetings, or we call them ICTs for short, are a very valuable tool at times, but we learned they were not always needed on a certain interval. So the revised model of care allows those ICTs to happen when needed, or like a family request, or a provider may request. So that just, again, taking into account the member's care management intensity. And then finally, in the last column, you can see many of the things we already highlighted. Next slide. Thank you. All right, so our managed care organizations will be processing all the information they have for our members and utilizing the data and information to stratify members into the appropriate care management category. So when we talk about managed care organization or MCO data analytics, it also includes how the MCOs are going to stratify members to determine the level of care management intensity. Again, that high, medium, low intensity. Here are the data sources, including in that methodology and scoring process, such as level of care, pharmacy, where someone lives and their zip code, perhaps in an area where there's not as many services. And this stratification is going to happen quarterly. So, very fluid, and that's very different. Next slide. All right. So here we are again with the levels of care management and priority positions. So this slide outlines populations for person-centered care management. The first column is a mandatory high, and this population must receive high-intensity care management. The second column is mandatory priority population, and this population must always receive care management, but can move between high and moderate depending on their status. And the last column is priority population, where you will see pregnant women and children. And the MCO determines which intensity, high, medium, or low, depending on the status of the member. And this population may move to care coordination if they are stable in the community. So you can see, exactly where we are. A woman who's at high-risk pregnancy is going to get that higher level, but once stable, can move maybe just to care coordination. Next slide. All right, and finally, we just wanted to demonstrate the pathways of receiving a member and their clinical status and care to determine what care management interventions are needed. And so, yep, we're talking about data, member screening, integrated care, but we are also considering quality and member satisfaction here. So, there's a lot of information I just gave you, and I left a few minutes for Q&A, but a lot to digest, I think. was a lot of information in a little bit of time. But you can, I think the next slide has some resources. I'd be very happy to give you my information. Maybe we can type it in the chat. My name is Lynn Vest, and I will get my information into the chat. But if you go to the DMAS Cardinal Care page, the member page, you can see a lot of information for members, a lot if you haven't been there, and a lot of information for providers. And Farouk says, I feel we could spend an hour talking about the quality piece. He's actually right. We could spend an hour almost on every slide. There's a lot of information. And then the Cardinal Care provider page. Any questions about Cardinal Care, you can reach out to CCNC contract at dmas.virginia.gov. And we've left you a lot of other emails so that you can go to specific people for your specific questions. But I always can be your go-to. I can get you where you need to go. I help families and members all the time get where they need to go, because we really want to have a no wrong door approach when members call DMAS, families, providers. It's very frustrating if you get moved around from place to place. So even if it's not an issue that I know of, I always make sure they're warmly transferred to the right person and make sure there's follow-up. So again, I'm happy to type in the chat my information, or I can get Hope to get it to you. I'm going to go ahead and just put in my email. But I can't thank you guys enough for having me. And I'm happy to take any questions. And if anything I can answer, I'm happy to take back as well.
Thank you, Lynn. Yeah, really a wealth of information, a lot of things I learned throughout the presentation, so I appreciate that.
Sure.
Do folks have any questions at the moment? Thank you for offering some follow-up information if questions come up later, but does anyone have any thoughts or questions at this point?
Freddie, this is Susan Brown. I just put my question in the chat, but when I was working at an MCO, we really struggled to get folks who qualified for care management to accept care management. We had trouble reaching them, helping them understand the value of care management. So I'm just curious what the expectations are and how the different MCOs will be, some may be more successful than others, and what that's going to mean for the program.
Oh, hi, this is Lynn. Hey, Susan, I used to actually work at a health plan too. So I understand exactly where you're coming from. And then my experience being, working directly with members. So the great thing obviously about Cardinal Care is everybody has access to care coordination, but there is a refusal, and everyone has a right to refuse it, right? I mean, that's just a right of every member. And we do a lot of trainings with our care coordinators, and I don't know if this is the best answer, but this is just an answer in that we do trainings with our care management unit that I'm also a part of. And we help our care coordinators when they have problems reaching out to members who don't want care coordination or unable to contact. And, we do provide trainings on, best practice. This is what sometimes, they see the insurance number come up and they're like, I'm not answering that, but we do go over best practice for those members. And sometimes they reach out to member services and they don't want care coordination. And then they find that, once somebody does reach out to them and kind of helps develop a relationship that, for the most part, most people who really are hesitant will come around after they've, had a little bit of time, especially if they're not used to it. But we have other members that just flat out refuse, and really is their right. And so, when they do have a problem, then they may say, I want care coordination for a time. I just don't want it all the time. And it really is member centric. So it really is up to the member. And again, just doing the trainings with the care coordinators, helping them have better ways to communicate with our members. So that our members don't feel like or families don't feel like they're being forced, into something, or that, participation or non-participation is going to have any impact on their healthcare. So I think it's really a lot of education from our care coordination. And then we, again, provide a lot of training on communication to our care coordinators. And we remain a resource to them as they bring up these issues as well.
Yeah, and sometimes it's a matter of timing. Sometimes folks are so overwhelmed, they don't really want to talk to one more person. They don't understand the value,
Yes.
but certainly one of the things we found most helpful is just to go back and revisit.
Yes.
Maybe a few months or even a year later, well, this is still a high risk person and we really think they would benefit. Let's try again to reach
Right.
out.
And you're right, Susan. There are actually guardrails that are built in to the contract and to the design so that care coordinators do you know, there are, depending on their you know, what their risk level is, they do reach out and they do say, we're here for you. Of course, unless someone flat out refuses and says, don't ever call me, you know. But they do work on that. And I've seen a lot of success from just going back. You're absolutely right.
Great, thank you.
We have high expectations with this new design, I have to say.
Great. Any other thoughts or questions? I think we have time for maybe one or two, if we have any. Okay. Well, I want to thank you, Lynn, for coming to present to us.
Thank you for
A
having me.
lot of food for thought, and really should be interesting to see how everything rolls out and how folks are getting connected to coverage.
Yeah,
So
and please don't hesitate to reach out. I'm available. Thank you so much.
great.
Mm.
Well, next up, we have a DBHDS update. Catherine and Bernadette, or should I say Dr. Knight, will be joining us to talk about school-based mental health services pilots. Are folks on?
Yes.
Yes.
Great.
So thank
Well,
you. Oh, I'm sorry.
no, I was just gonna invite you to unmute and to please take it away. Thank you.
Thanks, Freddie. And good afternoon, everyone. I'm Catherine Hunter. Right now, I'm serving as the acting director for the Office of Child and Family Services. And I am not going to speak for very long because we have our subject matter expert here, Bernadette Knight, who knows all things school-based mental health and will be able to provide an update for you all on what we have done up until this point, and then what we are planning to do for the future. So with that, I will turn it over to Bernadette.
Thanks, Catherine, and thanks, Freddie, and the rest of the CHIPAC committee for having us here today. We're super excited to talk about what we're doing at DBHDS for school-based mental health services. So yeah, so we'll just dive right in. Want to start off with our budget language that we had from the General Assembly that's guiding our work and direction at the agency as we're working with school-based mental health. And as you can see here, in fiscal year 23, we received $2.5 million. And we really had three main aims with this funding. One was to provide technical assistance to school divisions for those who are seeking to develop school-based mental health services. So giving them sort of the resources, the skills, and tools necessary to be successful with implementing school-based mental health. We also were charged with providing grants to school divisions. So if they were interested in seeking this and partner with us on the state level, we provided funding for the school divisions to in turn partner with a community organization. It could be public or private, so it could have been thinking USB, I'm thinking computer, CSB, a CSB or a local organization they have been working with that provides mental health services that can support their schools, or if they've been in an existing partnership, they could work with them to continue that funding as well. And then also one that's a little bit more internal to us, reporting back to the General Assembly on the findings of the pilot, and then also having recommendations to guide planning moving forward. Next slide, please. So as you all may or may not know, our initiative is a part of the governor's larger Right Help Right Now initiative, which is the behavioral health transformation that that's undergoing in the state now, and our agency is definitely, very closely plugged into this as we make that happen on, at the agency level. School-based mental health is one of those initiatives that is also tied into Right Help Right Now. And under this, the main things that really complement this is that there's providing that mental health support, the funding so that schools can provide that mental health support to students who are in need, and decreasing barriers to that, such as access and transportation and things of that nature. And then also this encourages that partnership with the school division and the community partners. So really enhancing that community health approach and really that partnership between the school divisions and the resources that they have in their own communities. Next slide, please. So now I'll shift a little bit and start talking about the focus of the initial pilot that we did and some of the things that we worked with the school divisions who did receive funding as they worked to implement their plans. Under the pilot project, we worked with school divisions as they were formulating their ideas to provide supports to schools, and we worked with them to include some of this in a multi-tiered systems of support. And what this is and this is something that's also our partners at DOE use, and I know there's also a Virginia tier systems of support, which is sort of a similar approach, but it's really a system to provide supports to students based on their need level. And so as you can see from the pyramid here, Tier 1 are more of your universal supports. So that may be like assemblies and programs that may occur in the schools that will support all children. If some of us, depending on where we were in our timeline in school, can remember back to maybe had assemblies on like drug awareness, things like that. That might be a Tier 1 support that would come into play that all students would receive to provide some level of prevention. Tier 2 is more, you get a little bit more targeted. So say for instance, there's some there may be a small group of students or that need some more intensive help or support with some things. So this may be where you would have more of a small group session with students. It might be a classroom or a couple students within that classroom if there's a something that you're trying to address as well. And then Tier 3 gets to the most intensive need of students. If it's something that's very specific to that student, their family, it may be something to where the school may need to work with their community partner to provide those services outside of what they can do at the school level. So this was the sort of the foundation model that we'd work with school divisions in our initial pilot to help sort of frame their approach and look at implementation of school-based mental health. Next slide, please. Yep. And so also in addition to that, like I mentioned before, we with the grant funding also provided technical assistance. This is where we partnered very closely with our sister agency, Department of Education. They worked really closely with us to provide a three-pronged approach for technical assistance. We have the first one, which is universal. We created some modules, really self-paced learning modules for those who may be interested in school-based mental health and just kind of learning some, just kind of the groundwork of what is it, what are some important things that need to be in play if you're seriously thinking about integrating a school-based mental health approach into your school setting. We have pre-implementation, which was for, we had 2 to 3 school divisions that that worked with us. And the pre-implementation is they know that they want to implement a school-based mental health program, but they're kind of needing to understand like what is their what strengths, what resources do they have available. So we worked with Amelia and Amherst, those school divisions, to really do like some needs assessment to understand like what are their strengths, what are their like some roadblocks to implementation, what resources do they have available, and like how they can bring things online to really get ready to implement when they're at that point that they feel comfortable and ready to implement school-based mental health services. And then the third one was our actual implementation technical assistance. And this was for the school divisions that'll come in a slide or two ahead in a second that received funding from us to implement school-based mental health. We did a series of webinars with them, Department of Education did, webinars with them, and they used a community of practice approach. So a group learning setting, they had different topics they would go over each week, like the importance of data collection, how to strengthen like your partnerships for school-based mental health implementation. And they also, had time on the calls to have peer-to-peer learning. So had the opportunity to sit in a couple of calls. So, they'd have group discussion. They could maybe piggyback some ideas off each other, or if one school was having a roadblock, they had a chance to kind of talk about it, and they could also share their successes as well. So like I mentioned before, we also provided the technical assistance to our school divisions because we really wanted to make sure that they had the knowledge and skills and resources to be able to implement school-based mental health. Next slide, please. All right, so with that, we had our timeline for implementation from the previous fiscal year. And so as you can see here, in summer of 22, we started really working with DOE to find school divisions who were, 1, interested in school-based mental health funding, but 2, also given that we were a little further along in the fiscal year, we wanted to work with schools who could readily come aboard and start services, because we wanted to be able to provide some support, but we were also wanted to make sure that there were schools who could come on board relatively quickly and start some program ramp up. So July and August interviewed schools to see who was interested and who might be a good fit. After that, in September onward, we went right into contracting after we got with schools that were interested and could move forward. And early 2023, we had our kickoff meeting in January, and then we went right into the implementation of their proposed services after that, and that went on from January to June of this year, this fiscal year. Next slide, please. So, I've been talking about the pilot schools quite a bit before we got to this, but just wanted to introduce the schools that were that did receive funding in the first round. So we did have 6 schools that that received funding in the first round of our pilot implementation, and these are the 6 schools here. These are examples of the partners that they worked with to implement. So as you can see, it was a mixture of public, private. Some wanted to work with their local CSBs, some wanted to work with other providers in the area who they may have already had an existing relationship with and was providing services. And so we had a range of those, and school divisions as well that that moved forward as our pilot schools. Next slide, please. And so now what I'll do is I'll shift a little bit into our data and our outcomes. During the pilot session, during the pilot implementation from the previous round, we did work with school divisions to collect data. As I mentioned in the timeline before, we started in January, and so we were working with within that fiscal year. So just kind of keep that in mind as we were kind of looking through the data and talking about some of the outcomes. But I think regardless of even with that time frame, I think the schools, given that, did a really good job and were able to move forward, given the time frame and the things that they had to work with. So in this slide, you can see here that a lot of our schools use the funding to provide services, most along all tiers. Bristol focused mainly on their tier 1 services to provide larger prevention to their students there. Hanover provided services within all their tiers, and then Hopewell and Lunenburg, they focus mainly on tiers 2 and 3. And so as you can see, it's a range of services that they provided. Like I mentioned with Bristol, they did a lot of suicide prevention. Hanover did motivational interviewing. And I know like with Lunenburg, they also focus a lot on sort of mentoring programs and something to support, like I mentioned, like that tier 3 support where you would think with targeted support to smaller groups of students. So just wanted to highlight some outcomes from the schools in terms of types of services and number of children that were served. Next slide, please. Yep. And also too, want to put a little bit of focus on Hanover again. They also implemented a calming room. They used some of the funding to develop a calming room at their schools. And so they shared with us some of their data with this in terms of how that went and the number of visits they had. And so as you can see from this graph, they implemented it over, I want to say 9 schools, if I'm counting correctly. Over their 9 schools. And so you can see like the total number of visits that they had for those calming rooms between November and May of 2023. And so in talking with them, I talked with our contact there, and they were saying they were really happy to have been able to provide that service. And there were some things that they kind of learned from that approach moving forward. And so, the sort of data person in me as well also, was glad to see, one, that the service was provided, but also how they were looking at this and saying, hey, this was a great success, but there are some things we also learned from this in terms of how we can maybe strengthen how we have access to the common room, like the data we might want to collect. So I know that this is still going on for them in terms of their common room. And so I'm sure over time, as they've been implementing this more and more, they've sort of refined how they use it, who their process of, who oversees that session and things like that. Next slide, please. All right, and so want to share a little bit more sort of information about school-based mental health. And this is not from the school division perspective, but information we gathered from stakeholders who are vested and interested in the success of school-based mental health. So earlier this year, we had a school-based mental health conference in Richmond, Virginia, the 6th and 7th. And so during that time, we had a focus group session. We really wanted to hear from participants about largely with Right Help right now and some of the initiatives that are based for school-based mental health and just children's health in general, but really wanting to get some of their impact, their feedback in terms of what would be needed to the resources that would be needed to expand school-based mental health in your community. What do you see as the biggest benefit of having behavioral health services? What do you see as the biggest barrier or roadblock, as I like to say, to implementing these? And then some key components that could be included in partnerships between school divisions and community agencies. So some of the things that came out here, and we'd also been hearing just in our larger conversations where we work with school divisions and just from stakeholders in general, the need for consistent funding, having a just the overall process, just understanding what school-based mental health is. So when we say that, what do we mean in terms of that for implementation across the state? Funding is, I think I mentioned a second ago, is definitely important, for sustainability and long-term implementation. So as you can see from here, there are, a range of themes that pulled out, but those are just some of the ones that I mentioned that we consistently hear that was reflected in this focus group, and also just we have in our larger conversations with stakeholders. Next slide, please. All right. And so sort of to kind of round it out and sort of wrap up sort of what we found from the pilot, just to talk about some of the successes and the challenges of the pilot. I think overall, from the funding, we were able to work with school divisions to contract for services. So they were able to get some services out of the door, to support their schools, their kids, and then also some training for staff. We were able to provide that technical assistance, as I mentioned earlier. So we worked with DOE very closely to provide that. So schools were able to get that support, and they were able to do some hiring from the funding that was allocated. Some of the challenges from this was that, I think I've kind of been sort of alluding to this throughout the presentation. We had sort of a short time frame to work within. We worked within that fiscal year to do the implementation, the contracting and things. So that really kind of ate up a lot of, ate into that fiscal year. So the schools had a truncated timeline to work within. And I think a larger thing that we all talk about that kind of goes beyond this conversation is the behavioral health workforce just although some schools were able to hire, we are having challenges with behavioral health workforce. So in some ways you have that, but in other ways it can be a barrier to schools being able to provide that service. And I think this graph on the side can kind of speak to that a little bit. If you look at it, you can see like sort of the ratio of what we awarded to what schools were able to spend. And some schools were able to spend, quite a bit of their funding. And for others, it was a challenge, and some of that was because of workforce. Workforce was a challenge in terms of being able to get those folks, hired and online. So we were definitely looking at that as the fiscal year went on, and so wanting to provide some level of support to the schools. I work with them really closely to say, hey, we're at this point. I understand you're not going to be able to hire at this point. What else can we potentially, help fund so you can provide services? So it may have been something to where we shifted to helping them buy a lot of training materials, or we helped them to buy a lot of curriculums, things that they could use so they could still provide some level of service. It just may not have been what we initially proposed, but we were very vested in the school divisions and wanted to make sure that we could support them in some capacity with this funding that we had. Next slide, please. And so from all of our efforts with school-based mental health, with school divisions, the feedback from our stakeholders, we had some recommendations that we provided to the Behavioral Health Commission in our report and in our oral report to them a couple months ago in terms of what we can do to support implementation of school-based mental health moving forward, and how we can help to promote and sustain more sustained actions moving forward. So as you can see here, I won't read all of them for you, but just to pick out a couple, working with our partners at DOE to make sure, allocation and funding decisions. So this is something that we've started with the initial work in the pilot, working closely with Department of Education on our technical assistance and having those conversations, because we value them as a partner, having that background on the school division level, which helps us be able to be successful in implementing school-based within the various schools. So this is something that we put forth as a recommendation, and we continue to do, working with them. So it kind of moves up to the secretariat level in terms of really shaping that policy and fiscal decisions, and helping to move the needle in how we work together on this. Establish shared outcomes using goals of schools and youth mental health outcomes. Again, it kind of gets to us working together between the two, but then also as we look to sustain and move forward with school-based mental health funding, the initial pilot provided us some groundwork in terms of what we can do, but moving forward, we want to have that common language so we all are on the same page when we're talking about certain things within school-based. And then also too, as we want to talk about share the successes and the outcomes, looking at what those measures might look like to talk about behavioral health outcomes, also talk about educational outcomes, and then also programmatic outcomes as well. Next slide, please. All right, so talked a lot about our initial pilot from the previous fiscal year. I'm going to shift a little bit gears and give you all sort of an overview of where we are now with school-based mental health. So going to go into like where we are now in the world of all things school-based mental health, and things that DBHDS and DOE are doing now. Next slide. So this may look familiar to everyone in terms of what we talked about earlier, but our overall aims for school-based mental health are largely the same. This fiscal year, we were given $7.5 million to continue and expand services. Our activities are largely the same: technical assistance to school divisions, grants to school divisions, and also reporting back to the General Assembly. And that actually, the language, I think I did a copy paste fail right there, so that's on me. That should say annually instead of September 1st, 2023, because we've already done that report. So same overall goals. Now we just have the funding this fiscal year to continue with school-based mental health work. Next slide. And so this just kind of gets a little bit more into detail about this, and I think the next slide will as well. But because of the interest in school-based mental health, and because we're working together with Department of Education, and there are other agencies. I know DMAS is also having conversations. There's lots of work that is happening around school-based mental health. So we anticipate that there will be, much more formalized collaboration down the line. So definitely want to recognize that up front, our current and future partners that will be in this effort. But right now we are working with doing an application process for this round of funding for schools that may be interested. And we're also working to do the groundwork to get our technical assistance and data collection underway. And so we'll be working, like I said, closely again with DOE on this in terms of as we work with the different components of school base. And next slide. Okay. So the project overview, just so you even a little bit more detail in terms of this round of funding. So we recently had an application open for school-based mental health funding for this round. It closed yesterday at 5. And with this round of funding, we did 3 information sessions with schools, for school divisions who were interested to learn more about this round of funding. Some of the things that we're looking for with this as they're putting forth their initiatives or potential initiatives for funding. So as I mentioned earlier, they still will establish a partnership with a community-based provider. It can still be public or private, so that hasn't changed. This year, as we're working towards helping the state have a more clear, sort of not clear, but as we're kind of moving towards a more standard way of talking about school-based mental health, we did ask that school divisions have their plans fall within that 3-tiered system. So we are requiring that schools for any services that they provide would have to fall within those 3 tiers. And then also, I think what didn't make it on here, but I'll just mention as well, we're also encouraging schools to use or requiring schools to use an evidence-based or informed practice within that. So this is something that we've kind of added into this year, whereas the pilot, we were working with schools to incorporate that in. Now we're asking them to include that in their applications as ways of just really having moving a process for school-based implementation. Still be providing technical assistance, and yeah. So next slide, please. All right, and so I think this is our last slide. This is where we are in our current timeline. As I mentioned earlier, we had our application that was open. It closed on the 5th. Sorry, I had to look at the date to see if it was the 6th or so. It closed on the 5th. So application process is closed. We're now getting ready to move into review of the applications. So we're on DBHS, and we're also working with our partners at DOE to look at those applications and review them. We're anticipating having a response to school divisions. I know we have here late December, but probably early January, just kind of given the Christmas break and everything, just, and going through the applications and getting things set up. So when we come back in 2024, we can start out the gate saying congratulations, want to get moving forward and start rocking and rolling then from January 24 onward. All right, and so that was everything for us. Again, thank you all for having us. We're always excited to talk about school-based mental health, and appreciate the time that you all give us to do the presentation. And I will open the floor for any questions that anyone may have about what we've done.
Thank you both, Catherine and Bernadette, for joining us and sharing about this. It definitely was really helpful. I thought that you shared both the successes and the limitations that can be kind of experienced by some of the pilot kind of timing and all of the budget and all of that. It's just really important as we think through our policy options in our own worlds, what those limitations what the impact of those limitations can look like. So I appreciate that. Yeah, so I reopen it up for any other questions or comments.
I have a question, Dr. Knight. Hi, this is Kimberly Mark. I work for DMAS. Just a little nosy question. When you were talking about the implementation of the calming rooms in the
Mhm.
schools,
Mhm.
as an intervention, are the schools collecting any data on how the calming rooms specifically impact behavior or mental health on the students?
That's a good question. I know when I worked with them before, they were just giving us a preliminary on how many students visit. I'm not sure if they've gotten to that level of detail in terms of that. But it's something we can definitely follow up on, and also too, as if there are schools that are providing that service now, that we would want to get that more information on that as well. So
Sure. Thank you. Just interested. Thanks so much.
yeah, no problem. All right. Well, thanks again, everybody. And yeah, happy to be here. And thank you all for having us to talk about school-based mental health.
Awesome. Thank you. Definitely an area of interest these recent years and moving forward. So appreciate all the work that you all do to implement these policies. All right. Well, I think next up we have agenda topics for our next CHIPAC meeting, which will be in person in March 7th, 2024. Hope, do you want to chat a little bit about that? Or?
Sure. Just I would say that if folks don't have ideas right now that they want to discuss, you still have the opportunity anytime between now and the first meeting of the new year, which I do not have the date in front of me. I think it's the bottom of the agenda, actually. Is it? Maybe not. The first executive subcommittee meeting of the new year, I believe is in January. So please feel free to reach out to myself or Freddie or Emily or Irma, any member of the CHIPAC executive subcommittee meeting. Thank you, Emily. January 12th. And folks are also welcome to attend those meetings. Anybody on the full committee, you're welcome to join for the discussion at the executive subcommittee meeting, which is really focused on the planning the agenda for the upcoming full committee meeting. So if there's something that you'd really like to see discussed in March, please feel free to join us in January.
Yeah, but if folks have any comments on that right now, we'll definitely take that. We'll be still. I think there'll still be some large decisions in terms of like budget and policy still to come after this date. So it's kind of hard to give a full outline in terms of what happened with session at that point, right? So just want to keep that in mind. Okay, well, it seems again, yeah, thanks, Hope. So if folks want to reach out, if there's any interests or topics that folks want to talk about, we can discuss it during our executive meeting. I think the last thing we have, and I see we already have some public comment in the chat, so I appreciate that. But if anyone wants to say something as a member of the public, I'm happy to have that. You can unmute yourself on your phone by pressing *6, or if you just want to leave a written comment in the chat, you are also welcome to do that. All right. Well, I think that is it for today's agenda. Definitely hope everyone has a healthy and safe, happy holiday season for folks, and definitely looking forward to getting together in person next time for our full meeting in March.
Great. And congratulations to our new committee leadership and happy holidays to everyone.